The next section, we're going to talk about the mechanism of action of local anesthetic with two objectives, including the mechanism of their action as well as the importance of pH and pKa in the action of local anesthetics. Local anesthetic block transmission of the action potential by inhibition of voltage-gated sodium ion channels. As you remember from neurophysiology, under normal or resting circumstances, the neural membrane has a negative potential of about minus 90. So the potential inside the nerve fiber is negative relative to the extracellular fluid. This negative potential is created by the active outward transport of sodium and inward transport of potassium ions combined with a membrane that's relatively leaky to potassium and relatively impermeable to sodium ions. With excitation of the nerve, there is an increase in the membrane permeability to sodium ion, causing a decrease in transmembrane potential. If a critical potential is reached, like the threshold potential, there is a rapid and self-sustaining influx of sodium ions resulting in depolarization, and once that's done, the resting membrane potential is reestablished. From an electrophysiologic standpoint, local anesthetics block conduction of neurotransmission by decreasing the rate of depolarization in response to excitation and preventing achievement of the threshold potential. But they don't really alter the resting transmembrane potential, and they have little to no effect on the threshold potential itself. Local anesthetic have a greater affinity for channels in the open or inactivated state compared to when the channel is in resting state. Local anesthetic binding to open or inactivated channels or both is facilitated by depolarization. The fraction of sodium channels that have bound local anesthetic increases with frequent depolarization, like during a painful stimulation. This phenomena is termed use-dependent block. But put another way, local anesthetic inhibition is both voltage and frequency dependent and is greater when nerve fibers are firing rapidly than with infrequent depolarizations. Local anesthetic binds with specific receptors that are within the inner vestibule of the sodium ion channels. And the commonly used injectable local anesthetics exist in two forms that are in dynamic equilibrium. One is the uncharged base that you can see in the red circle, and the other one is the protonated quaternary amine that's in blue. The neutral base allows the anesthetic to penetrate the nerve membrane to gain access to the receptor. Because it's not charged, it's more hydrophobic or lipophilic. And the charged form binds to the receptor and is responsible for the local anesthetic effect that's blocking the motor transmission. The relative proportion of charged and uncharged local anesthetic molecules is a function of the dissociation constant of the drug and the environmental pH. And as you remember from Henderson-Hasselbalch equation, you can see the dissociation constant, or Ka, be equal to pH minus log of a concentration of base over conjugated acid. If the concentration of the base and conjugate acid are equal, the latter portion of the equation cancels out because log of 1 is 0. So the pKa provides a useful way to describe the propensity of local anesthetic to exist in a charged or uncharged state. And the lower the pKa, the greater is the percentage of unionized fraction at a given pH. The pKa values of the commonly used injectable anesthetics are usually between 7.6 and 8.9. So this means that less than 1/2 of the molecules are in unionized at physiologic pH form. Because local anesthetics are poorly soluble in water, they're generally stored as water-soluble hydrochloride salts which are acidic, and this acidity contributes to the stability of local anesthetics, but potentially impairs the onset of block because it decreases the fraction of unionized local anesthetic. In the opposite scenario, bicarb is sometimes added to local anesthetic solutions to increase the unionized fraction in an effort to hasten the onset of anesthesia. And this can also help decrease the pain on injection of local anesthesia for still unknown reasons. Other conditions that lower pH, such as tissue acidosis produced by an infection, like in an abscess, can also have a negative impact on the onset and quality of local anesthetics. So, if you inject local anesthetic inside an abscess, it's going to be slower to kick in and it's not going to have an adequate effect. So, don't inject any local anesthetic inside an abscess. Lipid solubility of a local anesthetic affects its tissue penetration and its uptake in the nerve membrane. Lipid solubility generally correlates with local anesthetic potency and duration of action, and to a lesser extent, it varies inversely with latency or the time to onset of local anesthetic effect. Duration of the local anesthetic effect also correlates with the protein binding, which likely serves to retain anesthetic within the nerve. Nerve fibers can be classified according to the fiber diameter, presence or absence of myelin, and function. A larger diameter nerve has a more rapid nerve conduction, and the presence of myelin also increases the conduction velocity. With respect to local anesthetic effect, conduction blockade is predictably absent if at least 3 successive nodes of Ranvier are exposed to adequate concentration of local anesthetics. And in clinical practice, incremental increases in the concentration of the local anesthetic results in a progressive interruption of transmission of autonomic, sensory, and motor neuron impulses in an order, and therefore production of autonomic nervous system blockade followed by sensory anesthesia and finally skeletal muscle paralysis, again roughly in an orderly fashion. Local anesthetics are not equivalent in their propensity to induce differential blockade. For example, in equipotent dosing, etidocane produces more profound motor block than bupivacaine. And this characteristic is what makes bupivacaine a more valuable drug because we want sensory block, not motor block for the most part. And it also accounts for etidocane's limited use in clinical practice nowadays. When local anesthetics are deposited around the peripheral nerve, they diffuse from the outer surface or the mantle toward the center or core of the nerve along a concentration gradient. As a result, nerve fibers located in the mantle of the mixed nerves are blocked first. These mantle fibers are usually distributed to more proximal anatomic structures, whereas distal structures are innervated by deeper fibers. This anatomic arrangement accounts for the initial development of proximal anesthesia with subsequent distal involvement as local anesthetic diffuse to reach a more central core of the nerve fibers. As a result, skeletal muscle paralysis may precede the onset of sensory blockade if the motor nerve fibers are more superficial. And the sequence of onset and recovery from conduction blockade of the sympathetic, sensory, and motor nerve fibers in a mixed peripheral nerve depends as much or more on the anatomic location of the nerve fiber within the mixed nerve as under intrinsic sensitivity to local anesthetic.